So we're doing ophthalm and the year. All right. So the question was blurred vision, floaters in right eye, no ocular pain, fever or headache, history of AIDS with non-compliant with therapy, decreased vision in right eye, several white patches are present on the oropharyngeal mucosa. Fundoscopy findings were several yellow-white exudates immediately adjacent to the fovea and retinal vessels. So what could it be? Cytomegalovirus retinitis, herpes, HIV retinopathy, uh, ocular toxoplasmosis, syphilitic chorioretinitis, right? So this was CMV. Retinitis, cytomegalovirus retinitis, yellow, white, fluffy appearing areas of retinal necrosis. Okay. Retinal hemorrhage. Okay, so retinitis is the most common end organ manifestation of CMV in patients with advanced AIDS. It primarily occurs in those with CD4 counts less than 100 and generally presents with blurred vision, floaters, and photopsia, sensation of flashing lights. Fundoscopic examination is diagnostic and typically reveals yellow-white fluffy hemorrhagic lesions adjacent to the fovea and retinal vessels. Treatment would be valganciclovir. Differential was, if you thought it was herpes, then herpes simplex keratitis causes corneal, not retinal. That is important for another question as well, where you have to differentiate, and they give you the findings that it was corneal keratitis, right? However, here it was retinal. Okay, so several yellow-white exudates immediately adjacent to the fovea and retinal vessels, right? So that gives you a clue that it was the retinal one, and that's how you differentiate between these two. Okay. All right. Herpes zoster ophthalmicus presents with eye pain and a vesicular eruption, usually involving the cornea or iris. This patient does not have pain or rash or this. I don't think we would have picked any of the other ones. This was the only one where you had to differentiate between the two. I think that was a tough one, so we'll skip those. But it's there if you thought it was something else, you know. Yeah. Painless loss of vision while watching TV. Diabetes mellitus for 15 years. Fundoscopy shows that there's a loss of fundal details, floating debris, and dark red glow. So this is vitreous hemorrhage, proliferative diabetic retinopathy. Okay. Cause of acute painless vision loss. Diagnosis, symptoms, clinical findings, and management. Okay, so for central retinal artery occlusion, so symptoms would be severe vision loss with temporal sparing. History of amaurosis fogax. Clinical findings: pale fundus with cherry red spot, right? So that's the one. That's like the buzzword. Management here would be possible intra-arterial thrombolyticus, okay, ocular massage, or reduction of IOP, anterior chamber paracentesis, central retinal vein occlusion, blurred vision to severe vision loss. Okay, clinical findings would be fundus with retinal hemorrhage and optic disc edema, blood and thunder appearance. Okay, management here is observation with or without intravitreal injection of VEGF inhibitors. Uh, that's vascular endothelial growth factor. Okay. Retinal detachment. You'll have floaters, photopsia, which is flashing lights, progressive visual field defect. Okay. Clinical feature findings. Fundus with vitreous hemorrhage and marked elevation of retina. Management. Surgical correction, for example, retinopathy, vitrectomy, and typically is required. Okay. And vitreous hemorrhage, the one that this is. It has the dark glow. Okay. The dark glow comes from blood being in the vitreous humor. Okay, so hazy vision with or without red hue or vision loss, floaters, shadows. Clinical findings would be decreased or absent red reflex. Okay, decreased or absent red reflex. RBCs, floating debris, and vitreous obscured view of fundus. Management here is bed rest, HOB, that is head of bed. So bed rest, head of bed elevation, 30 to 45 degrees. Photocoagulation or vitrectomy is in some cases. Okay, so we do photocoagulation in this vitreous hemorrhage. Okay, and RVO, CRVO, we do VEGF inhibitors injections. For CRVO, we do thrombolytics. We use thrombolytics, ocular massage, reduction of intraocular pressure, retinal detachment. We do surgical correction. Okay. So this patient with vitreous hemorrhage, this patient with sudden painless vision loss and a dark red glow when the hemorrhage is dense enough, also causing loss of fundal details. On fundoscopic examination, most likely has bleeding within the usually clear and colorless vitreous, known as vitreous hemorrhage. Proliferative diabetic retinopathy, which can occur in patients with long-standing diabetes mellitus, is a common risk factor for vitreous hemorrhage. Okay, so this person had 15 years of diabetes. It makes the arteries uh, fragile, I guess is a word. Okay, so proliferative diabetic retinopathy, uh, which can occur in patients with long-standing diabetes mellitus, is a common risk factor for vitreous hemorrhage because the abnormal fragile blood vessels, fragile, that neovascularization on the neovascularization on the surface of the retina can spontaneously break and bleed into the vitreous. Intravitreal blood prevents light from reaching the retina, right? So that's why you have hazy vision, okay? Causing patients to experience sudden onset hazy vision, sometimes with a red hue or vision loss. Patients also may report seeing floaters or shadows. For example, that is due to floating blood clots. Okay. Uh, so pay attention to diabetes and history. That's a note I made. Right. If they have diabetes and then they're talking about red glow or something, it's probably vitreous hemorrhage. Diabetes causes neovascularization. Anything new is going to be fragile, like babies. There's a runner with AirPods. Uh, okay, went extra there. So runner with earphones in his ear, and when he took it out, left ear had green exudate. What is this? It's because of Pseudomonas, right? Acute otitis externa. Okay. We have Alzheimer patient, and they drool from corner of the mouth when fed. They have diabetes mellitus, type 2, multiple medications. They're taking it for it. Ear pain wakes up at night. Okay, so the ear pain causes them to wake up at night crying and holding the ear. Again, Alzheimer patient, probably 70 plus. Um, right ear shows granulation tissue with surrounding white drainage in the floor of the canal. Again, this is external ear. Chances are it's Pseudomonas. Tympanic membrane clear and responsive. So if it's causing drainage, there is granulation tissue, and it's waking them at night, then it's more than an acute otitis externa, right? It's going to be the malignant one, the necrotizing one. Tympanic membrane clear or responsive. facial asymmetry. The first aid reading pretty much covers this word to word. Causative organism and diagnosis, Pseudomonas, and we already talked about it, malignant otitis externa. Okay, so pathophysiology is life-threatening infectious complication of acute otitis externa, aggressive spread beyond external ear canal into skull base and adjacent tissue. Risk factors: older age, more than 60, diabetes mellitus, ear irrigation, cerumen removal. Microbiology, Pseudomonas aeruginosa. Clinical features: severe unremitting ear pain, worse at night when with chewing, purulent otorrhea, granulation tissue along floor of ear canal, with or without cranial nerve palsy, right? So this one, they had drool from corner of the mouth when being fed. That's because of that. Okay, cranial nerve palsy. So facial drool from cranial nerve 7 involvement, the facial nerve, and elevated ESR. Okay, that could be there too, because of inflammation. Treatment is IV anti-pseudomonal antibiotic, and that is ciprofloxacin. Remember that drug. Ciprofloxacin is the one we use for Pseudomonas or externa, otitis externa. Okay. Leukoplakia. Um, so with leukoplakia, I had a hard time grasping the concept of what oral leukoplakia is and what oral hairy leukoplakia is. I'm still iffy on it, but so this one is going to talk about that, and then I believe this one is about the hairy one right here. So if you are the same, pay extra attention now. So leukoplakia is white patches on the soft tissue of the mouth, like the buccal mucosa or the tongue. Uh, it's going to be non-scrapable, so when they try to remove it, uh, it doesn't go away. It is not cancer. However, it is pre-malignant condition. So if they're chewing tobacco, people, um, they put it under their tongue, and they usually put it on one side. So if they can't quit doing that, at least advise them to, move it to the other side, clean the white patches, and then use the other side. Keep switching the sides where you, uh, use tobacco. And of course, primary goal is to stop completely. So what caused this is the use of tobacco. Oral leukoplakia. Oral leukoplakia, risk factor, tobacco and alcohol use. Clinical feature, painless white mucosal patch, cannot be wiped off. Okay. Increased risk of cancer. This is non-homogeneous gross appearance, large size, more than 4 centimeter, dysplasia seen on biopsy. Management is biopsy at diagnosis and if appearance changes. Risk factor modification, for example, tobacco cessation. Okay, close monitoring, and they may need surgical excision. Okay, biopsy. So the management is the first step of management here is biopsy at diagnosis or if appearance changes. Okay, that's what they want us to do. Cool. All right. White lesion over the tongue, smokes daily, weight loss, multiple enlarged cervical lymph nodes bilaterally that are mobile and non-tender, bilateral corrugated adherent plaques located on the lateral tongue surfaces. So when you have this word right here, corrugated, that's a buzzword for oral hairy leukoplakia. Okay, that's different than this one. So next best step is going to be obtain HIV testing, obtain lymph node biopsy, perform laryngoscopy, prescribe oral nystatin swish and swallow, or recommend tobacco cessation and re-evaluation in 3 months. So this patient has multiple painless white mucosal lesions on the lateral tongue surfaces that cannot be scraped off. In addition, he has systemic symptoms including fatigue, unintentional weight loss, and cervical adenopathy. In a patient his age, that is young adult, this presentation is suspicious of oral hairy leukoplakia. Okay, so yeah, that's also another thing you gotta look out for, that it's someone young, right? Okay. A condition that is caused by intense Epstein-Barr virus replication and that is highly associated with HIV infection. Oral hairy leukoplakia typically presents as multiple white lesions on the lateral tongue with a distinct corrugated appearance. So corrugated appearance. Okay, buzzword. Because it occurs almost exclusively in patients with significant immunodeficiency, HIV testing should be performed. Okay, so that's the answer. Obtain HIV testing. Okay. HIV testing should be performed, especially in patients with signs of systemic illness. So differential diagnosis here for tobacco cessation. So tobacco cessation, right? That was a risk factor here. I mean, a management method here for oral leukoplakia. Here, also here you do biopsy at diagnosis and if appearance changes. Okay. Here, differential diagnosis, they said tobacco cessation and close follow-up is appropriate for biopsy-proven benign oral leukoplakia, a potentially pre-malignant lesion distinct from OHL, despite similarities in the name. Okay, so oral leukoplakia is pre-malignant. This one is not. Leukoplakia is more common in patients with a long history of tobacco and alcohol use. This patient's young age, systemic symptoms, and classic corrugated lesions on the lateral tongue surfaces are more consistent with OHL. Okay. So yeah. So this one happens because of smoking and all that. This one happens because of HIV infection. Okay. Or any immunodeficiencies. Cool. So that's majority of the differences there. This dude also smokes daily, but it's not this young at this age. It doesn't happen because of smoking. So that's why we obtain HIV testing, because it could be OHL. Cool, got it. So we have this eye. What do we see without even going into details about the case? What we see is red stuff. It's conjunctiva, conjunctivitis, right? But where you should be paying attention to is this junction right here between the cornea and the sclera, where you see little lines in the periphery right there, and that is a giveaway for uveitis. Okay. So we have a 35-year-old male with 3-day history of pain and redness in left eye. No fever, headache, nasal congestion, sore throat, episodic abdominal discomfort, and loose stools over the past 3 months. Okay, so loose stools. Again, for 3 months, loose stools, that is somewhat of a inflammatory condition, some type, right? Could be. History and mother with glaucoma. Okay, so here we have anterior uveitis as well with hypopia. Hypopion? What was it called? Something like that. Oh, hypopion. Yes. Okay. Painful eye with photophobia and congested conjunctival vessels. Okay. So anterior uveitis, that's what this was. So you pay attention to the abdo symptoms, which was Crohn's. Why is that important? It's because anterior uveitis is associated with inflammatory conditions. Okay. So anterior uveitis, iritis, and iridocyclitis is characterized by a painful red eye with tearing and decreased visual acuity. Examination findings include ciliary flush, pupillary constriction, a hazy flare in the aqueous humor, and hypopyon. Anterior uveitis is most often idiopathic or traumatic, but can be associated with systemic inflammatory disease such as certain infections, sarcoidosis, spondyloarthritis, and inflammatory bowel disease. So pay attention to abdominal symptoms and loose stools. Right. So this is again same thing over here. This image, congested conjunctival vessels right there. Pain and photophobia is there. Okay. Uh, Perilimbal injection. So that's the one that I told you to pay attention to. It's called the ciliary flush. Okay. So this is sclera. This is uveal tract. So that's where uveitis is concerned. So that's right between the sclera and cornea. Okay. This is the cornea right here. That's the sclera. So this right there. It's at the border, I guess. Okay. Iris, lens, cornea, anterior chamber, canal or schlemm, and vitreous body. So here we have normal limbus and iris. Anterior uveitis, pain, photophobia, perilimbo injection, ciliary flush, right? So that's the redness around the cornea, periphery, and hypopyon. Okay. So corner is spared of inflammation or exudate. Right. So this is how you know, differentiate it with, I guess, bacterial conjunctivitis. If you can't see the ciliary flush and you're still confused, you won't see exudate in the corner of the eye right here or here, right? As you would in a bacterial conjunctivitis. Okay. So corner is spared. So here, supposedly the corner is spared on this side. Okay. Okay. Blurred vision and right eye pain. Pain increases in bright light, so that's photophobia. History of 1 year, sleep problems, back pain, occasional heel pain. Okay, sounds like spondylitis. Obesity and um, hypertension is treated accordingly. Okay. Examination of the right eye shows redness of the sclera, which is prominent at the junction between the cornea and the sclera. Again, between the junction between the cornea and sclera. That's how they tell you that this is, again, uveitis. They're talking about ciliary flush. The right pupil is constricted, and there is photophobia with pen light examination. Okay, so in addition to treating the patient's eye, what's the next best step? Anti-RO SSA antibody assay, Lyme serology, MRI of the brain, rheumatoid factor, or X-ray of the sacroiliac joint. Okay, so even without this, just with this, you could tell it's something to do with, uh, sacroiliitis, spondyloarthritis, something like that, right? Okay. So anterior uveitis, presentation, symptoms, ocular pain, photophobia, decreased acuity. Examination is ciliary flush, pupillary constriction, hypopyon, common causes and association, infection, herpes, toxoplasmosis, syphilis, sarcoidosis, spondyloarthritis, ankylosing spondylitis, reactive arthritis, inflammatory bowel disease. Evaluation and testing is slit lamp examination, as indicated, HLA, B27, pelvis, spine x-ray, chest x-ray, HIV, and syphilis serology. Treatment here is dilating eye drops, for example, cyclopentolate, and topical glucocorticoids. Okay, so the answer here was x-ray of sacroiliac joints. Anterior uveitis with hypopyon, that's the WBCs gathered up there, right? Scleral hyperemia at the corneal margin, ciliary flush, layering of inflammatory cells in the anterior chamber is hypopyon. Left eye is left eye blurred vision, nausea, vomiting. Left eye stony, hard to touch. Okay, so it's stony, hard to touch. That's telling you that there's pressure in there, right? Left eye decreased visual acuity. Left eye red, hazy cornea, shallow chamber, dilated and fixed pupil. Okay, so hazy cornea, shallow chamber, dilated and fixed pupil. This is glaucoma. So how do you tell the difference between open angle and closed angle glaucoma? I believe, actually I don't want to say anything right now. We'll talk about it once we do open angle as well. So this was closed angle closure. Acute angle closure glaucoma can cause a red painful eye with diminished visual acuity. Yes. I believe in the open angle they don't cause the redness. However, it is more common in older patients. Okay, so that's also important. You gotta keep in mind about the age from 55 to 70. And most patients have headache, nausea, and vomiting. Examination reveals a red eye with steamy cornea and moderately dilated pupil that is non-reactive to light. Acute angle closure glaucoma is characterized by acute eye pain, headache, and nausea. Signs include conjunctival erythema, corneal opacification, and a mild dilated pupil. Okay. Gonioscopy is the gold standard for diagnosis. Ocular tonometry can be helpful if urgent ophthalmic consultation is unavailable. Okay, so gonioscopy number 1, and then comes the ocular tonometry in acute setting. Okay, now so we have, again, this is looking like uveitis, right? Because of this. However, if you look at the middle parts, they also have um, congestion. It's not spared. Okay, that's number 1. So, and also pay attention to the history. Here, history is about the person who wears extended lens but difficulty removing the lens for a week. Had difficulty removing it. So exudate is seen in the medial eye. Okay, so they're telling you that there's exudate in the medial eye corner and the lid margin prior to eye irrigation. What is the diagnosis here? Lens should give away that is Pseudomonas related bacterial conjunctivitis type thing. And then they tell you that the exudate is in the medial eye corner, right? So even though it seems like there's ciliary flush, they're telling you it's on the medial corner. And here we just read that it doesn't, it spares exudate in uveitis. So this is not uveitis, so don't pick that. This was bacterial keratitis, cornea, contact lens use, sclera, bacterial keratitis, pain, photophobia, corneal ulcer is seen, corneal opacification, sclera injection, mucopurulent discharge. Okay. Right. Sudden loss of vision in left eye on walking this morning. No associated pain. Smoker. Fundoscopic examination shows swelling of optic disc, retinal hemorrhages, dilated and tortuous vein, and cotton wool spots. Okay, so when they tell you that there's dilated and tortuous veins, that should tell you that there's something wrong with the flow of the vein, right? Something's blocking the vein. That's what's causing the dilation. And tortuous, right? And cotton wool spots as well. So all of these signs, the sudden loss of vision and unilateral eye, swelling of the optic disc, all of this, and retinal hemorrhage point to CRVO, that central retinal vein occlusion. Um, the buzzword there for step one was blood and thunder appearance. Right. Okay. Treatment for allergic rhinitis. For allergic rhinitis, what is it? So symptoms: you'll have rhinorrhea, nasal congestion, sneezing, nasal itching, um, cough, secondary to postnasal drip, ocular itching, and tearing. Physical examination shows allergic shiners, that's infraorbital edema and darkening. Okay. Allergic salute. This is transverse nasal crease. So that's this thing right here. Excuse me. Pale, bluish, enlarged turbinates. Pharyngeal cobblestoning. Allergic facies. High arched palate, open mouth breathing. Treatment here is allergen avoidance and intranasal corticosteroids. Okay, so intranasal corticosteroid for allergic rhinitis. Yeah, I believe it came up in when we did the recipe one as well. So allergic salute, what is that? That's this thing. Allergic salute. They call it what do they call it? There was another word for it that they used. I forgot. But anyways, that's basically what they mean. So doing that will cause the crease over there. So glucocorticoid nasal sprays are the most effective single agent for allergic rhinitis. Although maximal benefits may require continuous treatment for several days or weeks. Oral antihistamines, antihistamine or cromolyn nasal sprays, and leukotriene modifiers can be considered based on the patient's symptoms and drug tolerance. Okay. Ototoxic medications. Okay. So hold on. The right transverse nasal crease. I think that's what I was looking for. Transverse nasal crease, and it is also called the allergic salute. Okay. Ototoxic medications. These are aminoglycosides, antibiotics, chemotherapeutic agents like cisplatin, high dose salicylates. Okay, loop diuretics can cause hearing loss that may be either temporary or permanent. Ototoxicity is more common in patients taking high doses of loop diuretics, those with coexistent renal failure, or those also being treated with other known ototoxic medications, for example, aminoglycosides. Okay, so loop diuretics can cause hearing loss that may be either temporary or permanent. Ototoxicity is more common in patients taking high doses of loop diuretics, okay, those with coexisting renal failure, or those also being treated with other known ototoxic medications. But number one is aminoglycoside antibiotics, then chemotherapeutic agents, and then high dose salicylates. What about neuropathy then? Causes of toxic optic neuropathy. Okay, so causes of toxic optic neuropathy, antimicrobials are ethambutol, chloroquine, sulfonamides, and linezolid. Antiarrhythmics, digoxin, and imiodaron. Chemotherapy, vincristine, methotrexate. Other toxins, alcohol, for example, methanol, heavy metals, for example, lead and mercury, and carbon monoxide. Okay, so know these. Okay, ethambutol is there. Number one, I think that was the answer for the question. Chloroquine, sulfonamides, linezolid, digoxin, imidurone. vincristine, methotrexate, alcohol, methanol, carbon monoxide, okay, and heavy metals, lead, mercury. Cool. So 28-year-old female, gritty sensation and eye, rhinorrhea, sore throat, fever, intermittent, herpes, history of herpes labialis, mild eye injection and tarsal conjunctivitis, and profuse watery discharge. Recently returned to work as a kindergarten teacher. Next best step. Okay, so next best step was cool, moist compresses. Um, so here they gave you that it was watery discharge. Watery discharge is the only one that's associated with uh, viral, um, viral conjunctivitis, right? So there's conjunctivitis and watery discharge, that's viral cause, and KG teacher, right? So there's only one virus that is that fits the bill. That's adenovirus. Okay. Uh, so kindergarten teacher, right? Okay. Um, So diagnosis, common etiology and treatment, acute conjunctivitis, cause and treatment. Bacterial conjunctivitis, it's caused normally by Staphylococcus aureus, Streptococcus pneumoniae, and Pseudomonas contact lens. Treatment there would be erythromycin ointment or polymyxin trimethorphan drops or fluoroquinolone drops for contact lens wearers. Right. And viral conjunctivitis, so adenovirus is the common etiology. Treatment here would be supportive care. For example, warm and cold compresses, lubricating drops. Okay. We don't give antiviral. Okay. Antiviral drops or anything like that. Um, then comes allergic conjunctivitis. Um, Also, we don't give antibiotics either. Okay. Uh, even even though it makes sense that it's viral, you know, don't pick the bacterial one. Um, Allergic conjunctivitis, airborne allergens, for example, pollen, dust mites, pet dander. Okay, that's just like pet hair and stuff like that. Treatment here is antihistamine plus decongestant or mast cell stabilizer drops, for example, olopatadine and ketotifen. Okay. Sudden onset of redness, itching, and watery eyes. Okay, sounds like viral again. Uh, History of asthma. Oh, could be atopic. Okay, or allergic. Okay, so bilateral injection and granular appearance of the conjunctiva. Lungs have few scattered V's. Okay, so diagnosis: allergic conjunctivitis, anterior uveitis, atopic keratoconjunctivitis, bacterial conjunctivitis, and viral conjunctivitis. So we can cross out viral, bacterial, and anterior uveitis. We gotta pick between allergic conjunctivitis and atopic keratoconjunctivitis. For it to be atopic, I believe it can't be sudden onset. So since it's sudden onset, it's gonna be allergic. Okay. Acute and conjunctivitis, viral, bacterial, allergic. We already went through this, but again, distribution, viral, unilateral, okay, or bilateral, unilateral, bilateral for allergic, okay. Discharge is going to be watery for viral, mucoid. Uh, Conjunctival is going to be diffuse injection and follicular bumpy. Associated finding is viral prodrome, and duration is 1 to 2 weeks. Okay. Bacterial is going to be unilateral or bilateral, purulent discharge, diffuse injection, non-follicular conjunctiva. Uh, un okay, so that was non-follicular. This is follicular bumpy. Okay. Um, okay. Unremitting discharge reaccumulates within minutes and 1 to 2 weeks duration as well. Okay, so allergic, bilateral, watery discharge, diffuse injection, follicular, bumpy. So far, it's similar to viral, right? Associated finding is going to be ocular pruritus, the itching. Itching is the giveaway for this. Okay, so itching and watery eyes. Because there's no itching in viral conjunctivitis. Okay, is there? No, right? Yeah, no. It's gritty sensation, but that's not itching. Okay, so if you have itching, it's going to be allergic. Duration is less than 30 minutes, often sudden onset to perennial. Okay, here the star asterisk is red flags suggestive of alternate etiology. Decreased visual acuity, photophobia, pain with extraocular movement, and fixed distorted pupil. So acute allergic conjunctivitis causes bilateral conjunctival injection with watery discharge and granular or follicular tarsal conjunctiva. Okay, so when they say tarsal conjunctiva, they mean the inside of your lids. Okay, ocular pruritus is so like the backside of the lid. Okay, it's going to be granular and follicular, like cobblestone type. Ocular pruritus is a key feature that distinguishes allergic conjunctivitis from viral conjunctivitis. Okay, so that's important. That's how you differentiate between the two. Okay, ocular pruritus, the itching, is the key feature that distinguishes allergic conjunctivitis from viral conjunctivitis. Okay, if you're zoned out, pay attention to this line right there. Ocular pruritus, key feature that distinguishes allergic conjunctivitis from viral conjunctivitis. Okay, so DD, atopic keratoconjunctivitis is a form of allergic conjunctivitis in which redness, pruritus, and tearing are common, but patients have chronic, not acute, symptoms, often with photophobia and a foreign body sensation. Moreover, signs of chronic eyelid inflammation, for example, thickened, lichenified skin, are typical. And viral conjunctivitis, we already know that's not that, so I'm just gonna skip it. Presbyopia, okay, no, it's gonna bother me. Viral conjunctivitis, quickly. Like allergic conjunctivitis, patients develop watery discharge and granular tarsal conjunctiva, upper respiratory symptoms, rhinorrhea, usually accompanying ocular findings. In contrast to allergic conjunctivitis, ocular pruritus is uncommon, making this diagnosis less likely in this patient. Moreover, viral infections often start with unilateral conjunctival injection and involve the contralateral side within 1 to 2 days. Presbyopia is a common age-related decrease in lens elasticity that leads to difficulty with near vision. Okay. A history of a middle-aged individual who has to hold books at an arm's length to read is classic of presbyopia. Okay, so it is a decrease in lens elasticity. Okay, causes them difficulty with near vision. So increased lens opacity is the etiology of cataracts. This is different than decrease in lens elasticity. This is increased lens opacity. Okay, yeah, right. Is the etiology of cataract. Patients may have difficulty reading, but a history of difficulty with night vision or driving at night is more characteristic. Okay. Foreign body sensation in the eye, I think, and dry mouth. It sounds like Sjogren diagnosis. What's causing the foreign body sensation is the corneal ulceration. Okay, it was Sjogren's. Pathogenesis. This is immune-mediated destruction of the lacrimal and salivary glands. Okay, it's about the glands. It destroys the glands. Can occur as primary disease or secondary with other autoimmune disorder, for example, SLE and RA. Clinical features here are dry eyes, keratoconjunctivitis sicca, dry mouth, xerostomia, or salivary hypertrophy, dry skin, xerosis, Raynaud phenomenon, cutaneous vasculitis, positive antero SSA and or antila SSB. Complications: non-Hodgkin lymphoma, corneal damage, dental caries. 67-year-old man with progressive visual loss in right eye, history of smoke and alcohol abnormalities. Okay, so visual loss in right eye, history of smoke and alcohol and abnormalities. The patient has to cover his left eye and to look at a small spot on a grid made of parallel vertical and horizontal lines. He describes the vertical lines as being bent and wavy. Okay, so that is a classic uh, representation of age-related macular degeneration. Okay, um, which of the following is the most likely cause of this patient's complaint? Is it lens opacity, enlarged blind spot, increased intracranial ocular pressure, macular degeneration, or peripheral retinal degeneration? So when they tell you that the vertical lines are being bent or wavy, it's always going to be this. Okay, so macular degeneration is the most common cause of blindness in industrialized nation. Activities that require fine visual acuity are usually the first affected. Activities that require fine visual acuity are usually the first affected. And patients with this condition may report that straight grid lines appear curved. One of the earliest findings in macular degeneration is the distortion of straight lines such that they appear wavy. The grid test described above is frequently used to screen for patients with macular degeneration. Um, Sorry if I'm slurring my speech, it's because I'm really sleepy right now. But we gotta push through this. So the primary risk factor for macular degeneration is increasing age, although smoking can increase this risk as well. Patients may be asymptomatic, but others complain of visual problems in either one or both eyes. Driving and reading are often some of the first activities that are affected since they require fine visual acuity, which is provided primarily by the macula. In addition to the grid test described above, ophthalmic examination can identify drusen deposits in the macula, which are common lesions seen with this disorder. Okay, water break. Okay, we have a 35-year-old woman, episodic dizziness for 2 months. Okay, during the episodes, her right ear felt full and she heard a loud whistling sound in that ear. Episodes lasted 2 to 3 hours and resolved completely. Drinks 2 to 3 cups of coffee daily and 2 to 3 glasses of wine, plus BMI is 28. Audiogram shows moderate low frequency sensory neural hearing loss in right eye. Okay, so we have sensory neural hearing loss. We have oral fullness, right? We have whistling sound, so that is tinnitus. Okay, so that is the triad for Meniere's disease. Okay, so which of the following lifestyle modification strategies would have the most immediate effect on improving this patient's dizziness? Is it achieving 10% weight loss? BMI is 28. Increasing dietary salt intake? Uh, we don't recommend that unless they have like low blood pressure problems. Limiting caffeine and alcohol consumption. Um, they drink 2 to 3 cups of coffee daily and 2 to 3 glasses of wine, right? Um, Performing cardiovascular exercise 3 times per week, or that is similar to A, right? So DNA, if you have similar answers, those are probably not the ones to go with, because how can this be more correct than this, or how can this be more correct than this, right? Using an alternate form of contraception, sorry, contraception, okay. It doesn't mention anything about that here. Okay, so this seems like the right answer just from, normal elimination of choices. Let's see. This patient has episodic vertigo with hearing loss, tinnitus, and oral fullness, the classic triad of Meniere's disease, a disorder for the inner ear characterized by increased volume and pressure of endolymph. This is endolymphatic eye drops. The answer was C. Yeah, the limiting caffeine and alcohol consumption. Lifestyle modifications are first line therapy for Meniere's disease and include, so these are the 4 things that you do in Meniere's disease to manage it. One is dietary salt restriction. Here, the option said increasing it. We're here. They're telling us to restrict it. So 2 to 3 gram maximum per day. Sodium restriction may reduce endolymphatic fluid, thereby helping reduce endolymphatic eye drops. Limitation of caffeine and nicotine. Vasoconstrictors may reduce blood flow to inner ear. Okay. Okay. We want the blood flow, so the more the blood, the more interstitial fluid, the more lymph. Limitation of alcohol. Alcohol may cause fluid shifts that impact the inner ear. Okay. Limitation of alcohol. Alcohols may cause fluid shifts that impact the inner ear. Okay. And avoidance of allergy triggers. Both food and environmental allergies seem to trigger attacks in some patients, perhaps due to allergies leading to. Okay, let me just turn that off. Allergies leading to increased fluid extravasation into the endolymphatic sac. Improving sleep hygiene and stress management skills may also help. You're telling me. If lifestyle modifications fail to control symptoms, diuretics, for example hydrochlorothiazide, and or vasodilators, for example beta-histine, are often used. Vestibular suppressants, for example benzodiazepines and or antiemetics, for example promethazine, can be used during acute attack. Vestibular suppressants, for example benzodiazepines and our antiemetics can be used. Okay, right. Sorry, I'm just zoning out now. But again, to recap, Meniere's disease, we do lifestyle modification, starting with dietary salt restriction, then limiting caffeine and nicotine and alcohol, and avoiding allergic triggers. Okay. Okay. 28-year-old female. Persistent nasal congestion and stuffiness, constant sensation of dripping in the back of her throat, and states that food has tasted bland to her recently. Okay, so normally when it tastes bland, okay. History of fear, it's gonna be anosmia related something, right? When food tastes bland. Something like 70 to 90% of food taste comes from the smell. Constant sensation of dripping in the back of her throat. Okay, so it's something like allergic, probably. Okay. History of year ago ER due to severe wheezing after taking naproxen for cramps. Okay. Family history of asthma and a sister, and smokes weed. Okay. What's causing the symptoms? So is it allergic rhinitis, fungal rhinosinusitis, nasal polyposis, nasopharyngeal angiofibroma, perforated nasal septum, or pyogenic granuloma. So here, this would be an easy choice, right? Allergic, it's dripping and all that. However, they haven't given us history about that. What they gave us the history of is that she had severe wheezing after taking naproxen for cramps. Okay, so that was one. There's persistent nasal congestion and stuffiness, but we don't see anything like they mentioned here that, or where was it? Here, that for it to be allergic something, even though it's about conjunctivitis, it also applies to rhinitis. Airborne allergens, pollen, dust mites, or pet dander, right? So we're seeing allergic stuff. However, there's no history of allergy, and then they're telling us that she had gone to ER after taking naproxen, so she's allergic to naproxen. Okay, that's what it looks like, and this is related to polyposis. Okay, because that one, aspirin exacerbated respiratory disease is associated with nasal polyposis. Okay. This patient has persistent nasal symptoms and previously had a severe wheezing reaction after taking naproxen, a non-steroidal anti-inflammatory drug. This presentation is consistent with aspirin exacerbated respiratory disease, or AIRDS. The clinical triad of asthma, often severe and presenting in adulthood. Okay, 28-year-old. She's getting asthma attacks now. Okay. Bronchoscope, bronchospasm. This was the asthma attack, severe wheezing. Bronchospasms or nasal congestion following the ingestion of aspirin or NSAIDs. Okay. Chronic rhinosinusitis with nasal polyposis. Okay. This patient's current symptoms are bland tasting food, likely due to anosmia, and recurrent nasal discharge congestion are typical in patients with nasal polyps. Okay, so recurrent nasal discharge and congestion are typical in patients with nasal polyps, which are identified on nasal examination as bilateral gray glistening mucoid masses. ERGS is classified as a pseudo-allergy because it is not mediated by immunoglobulin E. Although the pathophysiology is not fully elucidated, it seems to be related to overproduction of leukotrienes. Exposure to NSAIDs leads to acute reactions in addition to typical management of asthma, for example, inhalers, and chronic rhinosinusitis, for example, intranasal saline and glucocorticoids. Leukotrienes modifying agents are often prescribed for patients with ERDS. Okay, so in addition to typical management of asthma, like inhalers and chronic rhinosinusitis, for example, intranasal saline and glucocorticoids, leukotriene modifying agents are also prescribed. ERDS is typically a clinical diagnosis but can be confirmed with an aspirin challenge. Aspirin desensitization is used for patients with worsening disease or those who require aspirin or NSAID therapy for comorbid conditions, for example, arthritis or coronary artery disease. Okay. How much? Nope. 10 more pages. Fundoscopy. Enlarged optic cup with an increased cup disc ratio. So that is a classic presentation of open angle glaucoma. They say like thinning of the optic disc, or like they said here, increased cup disc ratio, enlarged optic cup. But yeah, thinning is the one that is more popular as well. So this was primary angle, open angle glaucoma. Normal cup disc ratio is less than 0.5. Clear disc rim. Okay. There. Now, if you have open angle glaucoma, there's thinning of the disc. Okay. The rim, sorry, thinning of the disc rim. So there's enlarged cup and with cup disc ratio of more than 0.6, increase in cup size over time, thinning or disc rim of the disc rim, pale disc, optic nerve atrophy. Okay. Open angle glaucoma can be treated with a number of topical agents that lower intraocular pressure by decreasing the formation of aqueous humor or increasing its outflow from the anterior chamber. Okay, so outflow from the anterior chamber. The first line agent for most patients is lentoprost. And remember this. Always pick this. So first line agent for most patients is a topical prostaglandin, for example, lentoprost or bimatoprost, which acts by increasing drainage of aqueous humor through the uveoscleral pathway. Okay, the prostaglandins are ineffective. If prostaglandins are ineffective, topical beta blockers like timolol can be added, although they should be used with caution in patients with comorbid asthma. If topical agents are ineffective or not tolerated, surgical intervention, for example, laser trabeculoplasty, can be considered. Trabeculoplasty. Okay, so we have photos here of the medication. Okay, so trabecular meshwork right there. This is also trabecular meshwork right there. And this is the Schlem. Okay. Here we have ciliary body making aqueous humor going through the iris and down there. Okay. Ciliary body, vitreous humor lens. Okay, so here for what we can do in open angle glaucoma, we can block the aqueous humor inflow. So beta blockers or alpha 2 adrenergic receptor agonists, which are constrictors, right? And carbonic anhydrase inhibitors as well. Okay, acetazolamide, I think, if I'm not wrong. Or was it menthol? Let me go check up on it. Actually, I'm too lazy for that. Just check up on it. Which one that was. And put in the comment. The other one is uveoscleral outflow, prostaglandin agonists, okay, and trabecular outflow, muscarinic agonists. Okay. Open angle glaucoma can be treated with topical agents that lower intraocular pressure. The first line agent for most patients is a topical prostaglandin, for example, lentoprost, bimatoprost, which increases drainage of aqueous humor in the anterior chamber. If prostaglandins are ineffective, topical beta blockers, for example, timolol, can be added. Okay, so I just basically said the same thing. It's probably from a different question. Diabetic retinopathy. Diabetic retinopathy, non-proliferative. What was this? You see retinal hemorrhages, I think. Right? So little hemorrhages right there. Yeah, hemorrhage. This is macula. This is microaneurysms. Oh yeah, you will see microaneurysms. If you see things like this, it looks fake, but it's there. Hard exudates and optic disc, right? So if it looks like a little balloon with flashes on it, it's going to be diabetic retinopathy. Okay. You have neovascularization, these little tiny vessels on macula, optic disc as well. Okay. Patients with diabetic retinopathy are commonly and asymptomatic until late in the disease course. However, typical examination findings include microaneurysms, hard exudates, and retinal hemorrhages, sometimes with neovascularization. The disc is generally normal, and visual field defects when present are patchy rather than peripheral. Hypertensive retinopathy presents with blurred vision, sometimes with limited visual field defects. Examination shows arteriovenous nicking, copper wiring, okay, flame hemorrhages, cottonwool spots, and optic disc edema. Okay, so we have cottonwool spot, yes, nicking, yes, arteriolar narrowing. Okay, so it was thicker here and it's thinner here, and then it sticks there. Atriovenous nicking over there. Okay, okay. I don't see flame hemorrhages, but okay. So we gotta pay attention to little nickings. Okay, cottonwool spots. Where else did we see cottonwool spot? We saw it in CMV, our findings, right? We saw it in CRVO, central retinal vein occlusion as well. Okay, moving on. There's an older patient experiencing, older patients experiencing a progressive unilateral loss of central vision, most likely due to age-related macular degeneration. Okay, we already went over this. The macula is the portion of the retina responsible for central vision. In the macula, each cone synapses to a single bipolar cell that synapses to a single ganglion cell, in contrast to peripheral retina, where multiple cones converge onto a single ganglion cell. Because of this arrangement, visual acuity, sharpness contrast, and metabolic activities are greater in the macula than in any other area of the retina. Age-related macular degeneration is due to oxidative damage that accumulates with aging or smoking, the major modifiable risk factor for AMD. In the eye, the damage preferentially affects the retinal pigments epithelium, which contains the glial support cells for the retinal neurons. Retinal pigment epithelium degeneration results in accumulation of waste products, lipid, and protein deposits called drusen. Okay, so that's what the drusen is, this little stuff right there. Yellowish deposits of lipid and calcium, that is drusen, clustered around the macula. Okay. And dysfunction of overlying neurons, especially in metabolic active areas, that is macula. This leads to gradually worsening vision that preferentially affects central vision. Therefore, AMD can initially cause blurry vision and difficulty with contrast sensitivity, for example, reading and dark adaptation over time. Central paracentral dark spots and loss of central visual acuity can develop in the affected eye, with peripheral vision less likely to be affected. Age-related macular degeneration, dry. This is oxidative damage, waste product accumulation, tristan. This is not really high yield. I don't think this comes in handy anywhere, but let's just go through it. Degenerating photoreceptors, okay. So we have tristan deposition right under it. This is retinal pigment epithelium, okay, right there. Blood vessels of choroid. If it's wet we are talking about, then retinal hypoxia, increase in VEGF, and neovascularization, fragile and leaky vessels. So we have the RPE here. Under it, we have choroid plexus or vessels. They're causing new vessels to grow and new formation of vessels, and this is going to cause edema as well. Okay, going to look something like that. Okay, optic nerve right there. Okay. Age-related macular degeneration presents with slowly progressive central, not peripheral vision loss. Examination shows subretinal drusen and pigment anomalies. Okay, optic neuritis, optic disc edema, right here. Optic neuritis, gotta know what that is. It presents with acute monoocular vision loss and pain with extraocular movement. Examination shows unilateral optic disc edema. The condition often occurs in young women with multiple sclerosis. Okay, so that was the MS1. Monocular vision loss and pain with extraocular movement. What is this reminding me of? Oh yeah, okay. Vestibular neuritis. I think we came across that too up there. Okay. Where was it down here? It's somewhere. Actually, let me take a break here. Nasal congestion, rhinorrhea, and postnasal drip for more than a year. Plus, symptoms fluctuate in intensity. Symptoms worsen by cigarette smoke and strong fragrances. Nasal mucosa is boogie, and erythematous and rhinorrhea is clear. Normal conjunctiva. Symptoms don't change with seasons but worsen when going from indoors to outdoors on a cold day. Next best step, imaging of the sinuses, intranasal glucocorticoids, nasal cytology, radio allergen absorbent test, or serum IgE levels. Okay, so here we're dealing with non-allergic rhinitis. Okay, what is that? Its features are nasal congestion, rhinorrhea, sneezing, postnasal drainage, late onset, usually age more than 20, common. No obvious allergic triggers. Perineal symptoms may worsen with season changes. Erythematous nasal mucosa. Okay. Uh, Treatment here is mild intranasal antihistamines or glucocorticoids. If it's moderate to severe, then combination therapy. So here the answer was intranasal glucocorticoids. Allergic rhinitis is its features are watery rhinorrhea, sneezing, eye symptoms. There's no nasal congestion here. Okay, it's in fact pale or bluish nasal mucosa. You'll see. Um, Early age of onset, identifiable allergen or seasonal pattern. Okay, in this patient, there was no seasonal pattern, right? There was no obvious allergic trigger like fragrance and strong fragrances and worsened by smoke. They said. Um, Associated with so identifiable allergen or seasonal pattern, pale blue nasal mucosa. Okay. Um, Here the nasal mucosa was boogie and erythematous, so it was congested. Uh, Associated with other allergen disorders, for example, eczema, asthma, eustachian tube dysfunction. Okay. Cool. So treatment here was also intranasal glucocorticoids and antihistamines. So this patient has rhinitis triggered by small cell strong smells and sudden exposure to cold air. She lacks eye symptoms or triggers consistent with allergies. For example, seasonal variations and symptoms do not improve with oral antihistamines. This presentation is consistent with non-allergic rhinitis, also known as vasomotor rhinitis. Okay, so non-allergic rhinitis is also known as vasomotor rhinitis. In contrast to patients with allergic rhinitis, patients with non-allergic rhinitis usually cannot identify specific allergic triggers, for example, pollen counts, and they typically have negative testing for aeroallergens. However, many have very specific behavioral triggers, for example, walking into cold air, eating. In addition, uh, patients with non-allergic rhinitis typically lack the sneezing and allergic conjunctivitis. For example, itchy eyes, uh, itchy eyes, right? Injected conjunctiva that classically accompany allergic rhinitis. First line treatment for both allergic rhinitis and non-allergic rhinitis is intranasal glucocorticoids. Okay, so that makes it simple for us. Intranasal antihistamines, for example, azelastine and olopatadine, or intranasal ipratropium bromide can also be used. Combination therapy is often required for patients with moderate to severe symptoms. Differential diagnosis: serum IgE levels are usually elevated in allergic rhinitis, but not in non-allergic rhinitis. Okay. Okay. Continuous positive airway pressure predisposes users to recurrent epistaxis. Okay. Because of its drying effect on nasal mucosa. Humidification is often effective in preventing CPAP associated epistaxis. Okay. Presbycusis. This is sensory neural hearing loss that occurs with aging. Neural hearing loss that occurs with aging is called presbycusis. It presents with bilateral high frequency hearing loss and is related to damage to sensory neural structures in the inner ear. Cool. Ear pain. Pain wakes him up at night. Tests and examination is normal. History of general anxiety disorder treated with sertraline. Sertraline. The pain awakens the patient and increases in severity when he chews food. Okay, so this is when pain increases by chewing. It's usually TMJ joint disorder. Okay, excuse me. Diagnosis as eustachian tube dysfunction, giant cell arteritis, glossopharyngeal neuralgia. Uh, right, jaw claudication does happen in GCA as well, but there's um, so you're gonna have to differentiate it with that, I guess. Glossopharyngeal neuralgia, occult malignancy, and temporomandibular joint disorder. Temporomandibular joint disorder, risk factors, joint trauma, for example, injury, bruxism, psychiatric illness, for example, anxiety, history of abuse, clinical manifestations, facial pain, worsens with jaw motion, ear pain, tinnitus, headache, unilateral, worse or on awakening, and jaw dysfunction. Uh, Diagnosis, clinical imaging, not typically needed. Tender or mastication muscles, tooth wear, evidence of bruxism, crepitus or clinic clicking with TMJ motion. Management is education, avoidance of triggers, soft diet, uh, dental splints if bruxism suspected, and NSAIDs like naproxen. Okay. Um, I should delete this for GCA. If someone comes across this question and remembers that we want to do it between these two, you can write it in the comment section why it's not GCA. I don't remember the question for this one, but I'm pretty sure they explained it, so you're able to cross that one out. Okay. Um, 9-year-old redness in eye, mother denies trauma. Okay, so it's a 9-year-old and redness in eye, but it's not painful and denies trauma. So there's subconjunctival hemorrhage right there. Okay. So next best step is coagulation studies, fluorescence eye examination, formal visual field testing, measurement of intraocular pressure, or reassurance. Since there's no pain and it's just subconjunctival hemorrhage, it's going to go from red to yellow and then disappear, so we can just reassure them. Okay, so thin flat line or layer of blood between the conjunctiva or sclera. Subconjunctival hemorrhage is a benign condition in which blood collects in the space between the conjunctiva and the sclera. Uh, Patients are typically asymptomatic. The diagnosis is clinical and no treatment is necessary, so reassurance. Okay. 65-year-old, blurred vision in both eyes, 2 months. Okay, so blurry vision for 2 months. 65-year-old, no eye pain or redness. 10-year history of hypertension and diabetes mellitus, and non-adherent to treatment. Okay. So 10 years, hypertension and diabetes, and now they have blurry vision. Blood pressure is 150/90. Fundoscopy reveals bilateral scattered microaneurysms. So if we remember this from the diabetic picture, right? There were balloons on the arteries. Dot and blot hemorrhages and retinal hard exudates. Okay, what's over here? Right, this one. So the balloon shaped aneurysms, microaneurysms. So this was diabetic. So okay, that's a buzzword. Dot and blot hemorrhages and retinal hard exudates. Sorry. Next best step: blood pressure reduction and follow-up, CT angiography of the head and neck, evaluation for photocoagulation therapy, MRI of the orbits and brain, smoking cessation, and antioxidant therapy. Only 26% got the correct answer. Book has a different answer. So if I remember this correctly, the book suggests that blood pressure reduction happens. Another one was smoking cessation happens. However, the correct answer was evaluation for photocoagulation therapy. Okay, so we'll go into that. So this was diabetic retinopathy, non-proliferative. This is hemorrhages, macula, optic disc, microaneurysm, hard exudate. Diabetic retinopathy, proliferative. So PDR, proliferative diabetic retinopathy. Okay. Optic disc, macula, neovascularization. Okay. This patient with long-standing diabetes mellitus and bilateral blurred vision has fundoscopic findings classic for advanced non-proliferative diabetic retinopathy. What made it advanced? That there's blurry vision. Okay. Um, so that. Okay. Chronic hyperglycemia causes microvascular damage to retinal capillaries, leading to outpouchings, microaneurysms that can rupture. This is the what causes the dot and blot hemorrhages. Other changes include macular edema, capillary leakage, hard exudates, insoluble lipids, and cotton wool spots. Retinal nerve ischemia. Chronic uh, retinal ischemia stimulates abnormal vessel formation, neovascularization, signaling progression to proliferative DR. Okay, so chronic retinal ischemia stimulates abnormal vessel formation. This is neovascularization, and this signaling progression to proliferative DR. Okay, so when neovascularization initiates, that's when we go from whatever it was to progression to proliferative DR. Okay, so proliferation is what neovascularization is. Okay, not yet seen in this patient. Okay, so we haven't seen neovascularization yet. Uh, Optimizing glycemic control is essential for both preventing and slowing disease progression. Progression. Okay. Optimizing glycemic control is essential for both preventing and slowing disease progression. Regular fundoscopic examinations are recommended. Once DR is established, treatment focuses on reducing progression and managing associated sight-threatening complications, for example, macular edema. The mainstay of treatment includes the following. Okay, so these are the mainstay of the thing. Okay. The question was next best step. Okay. But it's not PDR, they said. Okay. Not yet seen in this patient. Okay. So the mainstay of the treatment is vascular endothelial growth factor or VEGF inhibitor. Because elevated VEGF levels induced by retinal ischemia promote angiogenesis and increase capillary permeability. VEGF inhibitor via multiple serial intravitreal injections prevent or reduce both neovascularization and macular edema. That is not in the option, right? So what's next? Retinal laser photocoagulation. Coagulation scarring of the abnormal or fragile retinal vessels helps prevent stop capillary hemorrhage, leakage, for example, macular edema, and proliferation. It is often used in non-adherent patients because fewer procedures are needed for benefit in contrast to VEGF. So that's why we went with evaluation for photocoagulation therapy because he is non-adherent to treatment for 10 years. Okay, so objective here was diabetic retinopathy is characterized by microaneurysm, hemorrhages, hard exudates, and cotton wool spots. It can progress to neovascularization. This is PDR. The mainstay of treatment are retinal laser photocoagulation and VEGF inhibition via intravitreal injections. Differential diagnosis. Uncontrolled hypertension can lead to retinopathy that has some overlapping features with DR. It can also worsen DR. Optimizing blood pressure control is important for slowing the progression of DR, but this patient's vision will not improve without retina directed treatment. Okay, so that's how we improve that. First, we want to improve the retina, the blurry vision basically, and then we go to the VEGF and cessation of smoking or controlling the hypertension, all that stuff. Okay. Infectious keratitis causes eye pain, redness, photophobia, and blurred vision. Slit lamp examination revealing branching dendritic corneal ulceration is diagnostic of right. So if you see dendritic ulcerations, uh, especially the corneal ones, make sure it's not retinal because retinal is different. I believe that was CMV, was it? Let me go check. Right, so herpes simplex causes corneal, not retinal, right? So yes, if you're seeing okay, they did not say which one causes the retinal one, in fact. But we'll go over here. So yeah, dendritic corneal ulceration. Um, if you don't know what that looks like, they have an image in first aid as well. We went over it there. Just Google it. Is diagnostic for herpes simplex virus keratitis. Patients with HIV are at increased risk. So infectious keratitis, pathogens, bacteria, Staphylococcus aureus or Pseudomonas, risk factors, improper contact lens use or corneal trauma or foreign body. Clinical features are central round ulcers, stromal abscess, mucopurulent discharge, and acute presentation. Okay. Herpes simplex virus, immunocompromised HIV, branch dendritic ulcerations, decreased corneal sensation, watery discharge, recurrent episodes. And if it's candida or fungi, it happens in immunocompromised with corneal injury involving contaminated soil, for example, gardening. Clinical feature here is ulceration with feathery margins and satellite lesions, mucopurulent discharge, indolent course. Okay, so here ulcerations are with feathery margins and satellite lesions, and you will have mucopurulent discharge here as well. In herpes, it's watery discharge, and in bacterial, it's also mucopurulent discharge, and it has acute presentation. This one has recurrent episodes. This one is indolent course. 81-year-old with severe pain in the right side of the forehead and the right eye over past 2 days. Okay, so forehead, not many things involve that, right? And if it's on the right side only, that means it's right-sided pain on forehead as well, and right eye. That gives you a clue that it's probably a nerve pain. Pain is burning, so when it's burning, it's a radiating type pain, so nerves are involved. Okay. Intermittently stabbing in quality. On physical examination, the right side of the forehead, nasal side wall, and eyelids are hypertensive to touch. So again, that's nerve pain, and contains scattered erythematous papules. Okay. Um, so highlighted against GCA basically, right? And this is, yeah, because remember, GCA can happen in a man as well. It's not just limited to women. And contains scattered erythematous papules. The right eye is red, with chemosis of the conjunctiva and increased tearing. Okay, so it hurts as well. So it's kind of like the trigeminal neuralgia type thing as well. So what is the treatment here? Um, this is herpes zoster ophthalmicus. It is characterized by a painful dermatomatous rash. Okay, so it would have been trigeminal neuralgia. However, they told us that it contains scattered erythematous papules. So that was a giveaway for that. Okay. Um, okay. Is characterized by painful um, dermatomatous rash and eye involvement. It is caused by reactivation of varicella zoster virus in the V1 division of the trigeminal nerve and is treated with systemic antiviral therapy. What was V1? It was ophthalmic branch of trigeminal. V2 was maxillary branch of trigeminal, and then we had mandibular branch of trigeminal nerve. Okay. Right, so antiviral therapy is what we give, acyclovir, famciclovir, or valciclovir, any of those. Okay. Okay, so this picture right here, and you see this little white spots. Okay, so this is external hordeolum. Um, Redness gives away the inflammation. Okay, so it is an acute inflammatory disorder and the white stuff is of the eyelash follicle or tear glands. Okay, and presents as an erythematous tender nodule at the lid margin. It is often due to infection with Staphylococcus aureus, but can be sterile. Initial treatment includes warm compresses. Okay. Erythromycin ophthalmic ointment is used for treatment of bacterial conjunctivitis and in the prevention of ophthalmia neonatrium due to Neisseria gonorrhea. Topical antibiotics are often prescribed for hordeolum but are usually unnecessary. Okay. So topical antibiotics are often prescribed for hordelum but are usually unnecessary. So erythromycin ophthalmic ointment is used for treatment of bacterial conjunctivitis and in prevention of ophthalmia neonatum due to Neisseria gonorrhea. Okay, but we don't give oral topical. I mean, topical antibiotics are often prescribed by hordelum. Okay, so initially all we do is just warm compresses. Okay, that's what the mainstay of this is. Um, these are given, but it's to prevent Neisseria gonorrhea in babies. Topical antibiotics are usually prescribed with these, but it is usually unnecessary. It doesn't help. Okay. So treatment in necrotizing malignant otitis externa, we went over this. IV ciprofloxacin, anti-pseudomonas. Okay, a 36-year-old woman, constant spinning sensation associated with nausea and vomiting. This is vertigo. Onset of symptoms 2 days ago. Feeling unsteady when walking. 2 weeks ago, she had an upper respiratory infection with sore throat, right ear fullness, and a feeling of muffled hearing. Okay, so let's see. We have that. We have spinning. So vertigo. Okay. And we have upper respiratory infection in recent times. Okay. And a feeling of muffled hearing. That's again fullness. Those symptoms resolved spontaneously after a few days. And history of childhood asthma, and her only medication is combined oral contraceptive pill. This patient's history is most consistent with which of the following diagnoses? Okay, this is called vestibular uh, neuritis. Okay, that's what this was. Um, let's go over the vertigos. So, common cause of vertigo, Meniere's disease. This is recurrent episodes lasting 20 minutes to several hours. Okay, so 20 minutes to several hours. This was, how long did they say this was? 2 days ago. Okay, so it's been longer than 20 minutes and several hours. Sensory neural hearing loss, tinnitus, and or feeling of fullness in the ear. Okay, sensory neural sensory neural hearing loss, tinnitus, or and ear fullness. That's Meniere's disease. So benign proximal, whatever BPPV was. Oh yeah, benign proximal positional vertigo. There we go. Brief episodes triggered by head movements. Okay, and you do Dix-Hell-Pike maneuver, causing nystagmus. Vestibular neuritis. This is acute single episode that can last days. Often follows viral syndrome. Abnormal head thrust test. Okay, abnormal head thrust test. Margin. Sorry, migraine. Vertigo associated with headache or other migraneous phenomenon like visual aura. Symptoms resolve completely between episodes. Then we have brainstem cerebellar stroke. This is sudden onset, persistent vertigo, usually other neurologic symptoms. So this patient has acute sustained vertigo without other neurologic deficit, consistent with vestibular neuritis. Okay, vestibular neuritis is an inflammatory disorder affecting the vestibular branch of the eighth cranial nerve that sometimes follows a viral infection. Vestibular neuritis can be associated with significant nausea, vomiting, and gait impairment. Patient sways towards affected side. Vestibular neuritis, combined with unilateral hearing loss, is termed labyrinthitis. Okay. concurrent cochlear branch and or labyrinth involvement. Diagnosis of uh, vestibular neuritis is based on clinical findings. Okay. Patients exhibit nystagmus that is suppressed by visual fixation, consistent with peripheral rather than central vertigo. Okay, so patient exhibits nystagmus that is suppressed by visual fixation. Cool. Um, that is consistent with peripheral vertigo. Uh, Head impulse or thrust test is usually abnormal due to impairment of the vestibulo-ocular reflex. In this test, the patient attempts to maintain focus on a distant target while the head is rapidly rotated left and then right. Patient with normal vestibular function can keep their eyes on target. However, patients with peripheral vestibular lesions such as vestibular neuritis have their eyes dragged off target by head rotation towards the lesion, followed by a corrective saccade back to target. Okay. Because VN is usually self-limited, patients with patients can typically be managed symptomatically with vestibular suppressants like meclizine and antiemetics. Corticosteroids may improve short-term recovery, and vestibular rehabilitation can improve residual imbalance. Objective: vestibular neuritis is a self-limited inflammatory disorder affecting the vestibular branch of the 8th cranial nerve that sometimes follows a viral infection. Vestibular neuritis with unilateral hearing loss is termed labyrinthitis. Vicious cycle of rhinitis medicamentosa. Okay, so nasal congestion, you take oxymetazoline, it stimulates alpha adrenergic receptors. Okay, so that causes vasoconstriction. The vasoconstriction causes nasal relief, but prolonged use of oxymetazoline damages vascular endothelium. Okay, this causes increased vascular permeability. That leads to increase in interstitial edema as well, and this will cause nasal congestion. Okay, so if you prescribe it to someone, it's or you take it, it's like take it for like 3 days. Don't take it longer than that, and yeah, not for long term. Shouldn't do that. At least 2 nasal congestion. Key. 74-year-old woman comes to the office due to several days of right ear pain, plus 2 episodes of dizziness and almost fell. Currently taking trimethorphan sulfamethoxazole for an uncomplicated urinary tract infection. Ear examination reveals several erythematous vesicles in the right external auditory canal with no drainage. The tympanic membrane is visible and intact. There is mild right-sided facial droop, which is the most likely cause of this patient's illness. Borrelia burgdorferi, herpes simplex virus type 1, Pseudomonas aeruginosa, Steven-Johnson's syndrome, varicella zoster virus. So we can here cross out A, we can cross out D, right? Herpes simplex virus type 1. Um, so we gotta do it between that. We gotta do it between uh, Pseudomonas and varicella zoster. Okay, so here we have uh, several several days of ear pain, 2 episodes of dizziness, and almost fell. Okay. Um, Give me a second. Where were we? So 2 episodes of dizziness and almost fell. Okay. Currently taking TMPSMX. Okay. Ear examination reveals several erythematous vesicles. Okay. And right, so remember the vesicle thing where we were talking about trigeminal neuralgia, it would have been, but then there were vesicles, so then it was herpes zoster ophthalmicus. It's similar thing here as well. Um, the vesicles, so herpes simplex, Pseudomonas doesn't do that, so we can cross that out. Well, it does actually. Hold on. In the right ear, external auditory canal with no drainage. Right, so gonadal DD for this. The tympanic membrane is visible and intact. There is mild right-sided facial droop. Okay, so facial droop. That's also an important thing to consider. Okay, let's just go read this. This patient with a vesicular ear rash and facial droop likely has herpes zoster oticus. So it's like, okay, so this is Ramsay Hunt syndrome, or Ramsay. What, like, is that how you spell it? Yeah, Ramsay. This condition is caused by the reactivation of varicella zoster virus from the geniculate ganglion, disrupting motor fibers of cranial nerve 7 facial nerve, with subsequent spread to cranial nerve 8, vestibulocochlear nerve. The two defining manifestations are a painful erythematous vesicular rash on the auditory canal or auricle, and ipsilateral facial paralysis. Okay, so that and that was important here. Many patients also develop vestibular, for example, vertigo or nausea, vomiting, hearing, and taste disturbances, but systemic symptoms, for example, fever are rare, less than 20%. Treatment with an antiviral medication, for example, valacyclovir, may speed resolution and limit adverse outcomes. However, many patients are left with residual facial muscle weakness and paralysis. Okay, so DD of these. The reactivation of herpes simplex virus type 1 is the leading cause of Bell's palsy, acute onset, unilateral facial paralysis. However, HSV usually causes vesicular lesions on the oral mucosa, not the auditory canal. Okay, so that's why it wasn't this. The presence of ear lesions makes varicella zoster reactivation far more likely. Pseudomonas aeruginosa is the leading cause of acute external otitis, which is common in swimmers and usually marked by ear itching and pain. Physical examination typically reveals thick, purulent discharge from the ear canal, unlike this patient. Vesicular lesions are not a common feature, okay, of this illness. Okay, so physical examination reveals thick, purulent discharge. Here they told us there was no discharge, okay? And that's how you differentiate between these. Okay, I just made note of which conditions gives you cotton wool on funduscopy. So that's what this is. It's not something you need to know. It's just for me. It was HIV retinopathy, central retinal vein occlusion, hypertensive retinopathy, and diabetic retinopathy. Okay, these gave us cotton wool. Androsin was seen in age-related macular degeneration, and okay, so only age-related. Okay, cool. All right, and that's it. See you in the next one.